Hello and welcome to the Laboratory Matters, where we discuss all that matters in a laboratory. We are at the concluding module of our course entitled Decoding Diabetes Mellitus in the Laboratory, where in the last three modules we've learned about glucose metabolism, the definition of diabetes, the sample collection, the storage, the transport, the various tests that can be done in the laboratory, starting from a simple glucose to more complicated tests that are used both for the diagnosis and the monitoring of diabetes mellitus, which is so common in our country. In module 4, we will learn how to use these tests to actually diagnose the condition. So which means what are the guidelines for the diagnosis of diabetes and what are the tests that we use to monitor a known patient of diabetes mellitus, including how to predict the various complications. So for the diagnosis of this condition, we commonly use what is known as the ADA criteria or the American Diabetes Association criteria. They keep modifying this criteria usually annually, and the values for the various tests sometimes change based upon their research, based upon what their findings are in the previous year. Now, according to the ADA criteria, the most commonly used tests for the diagnosis is glycated hemoglobin, plasma glucose fasting, oral glucose tolerance test 2 hours post glucose, and a plasma glucose random. So the various criteria depend upon the values that we get for each of these tests. So we've seen how slowly glycated hemoglobin has become the test of choice for the diagnosis of diabetes mellitus. So we'll take each one of them one by one. So we'll first start with glycated hemoglobin. The normal levels of glycated hemoglobin, or in a non-diabetic person, it is less than 5.7%. Now, if you have a HbA1c between 5.7 and 6.4%, then that state is called pre-diabetes. So one needs to control your sugars, do lifestyle modifications when you are labeled a pre-diabetic. HbA1c levels greater than or equal to 6.5% constitutes a diagnosis of diabetes. So today we've got diabetes diagnosed at a glycated hemoglobin value greater than or equal to 6.5%. So this one single test today will tell you or will classify you or will label you as a diabetic because it is taking an average 3-month glucose level and therefore it's a better predictor of all the other tests. So this is the number one test for the diagnosis of diabetes mellitus. Now let's move on to fasting plasma glucose. It's not lost its sheen as yet. Still we are using it. So the normal fasting glucose is less than 100 milligrams per deciliter. If you have between 100 and 126 milligrams, you're called a pre-diabetic. This is between HbA1c of 5.7 to 6.4. Similarly is greater than 100 to less than 126. And if your fasting plasma glucose is greater than or equal to 126, you can diagnose diabetes. So diabetes is diagnosed at a fasting plasma glucose greater than or equal to 126 milligram per deciliter. Now we move on to an oral glucose tolerance test. I told you how we can do this test. So when you take your 2-hour sample, that is after you have administered 75 grams of oral glucose to the patient, and you take a 2-hour post-glucose sample, the normal should be less than 140 milligrams per deciliter. If you are between 140 and 199, you will be labeled a pre-diabetic. and a diabetic will be greater than 200 milligrams per deciliter. So a 2-hour glucose value greater than or equal to 200 milligrams per deciliter will be diagnosed as diabetes. Now, supposing you can only measure the random plasma glucose for whatever reason, the normal is less than 120 milligram per deciliter, and if it is greater than 200 milligram per deciliter, you can diagnose diabetes. So, to put it in a nutshell, you use glycated hemoglobin greater than 6.5. You use a random plasma glucose greater than or equal to 200. You use a 2-hour glucose greater than 200, and you use a fasting sample which is greater than 126. So these values will be any of these values which are greater than the ones I mentioned to you. You will label the patient as a patient who has diabetes mellitus. So you don't have to do a whole battery of tests. You can do any of these to arrive at a diagnosis. So, do I have to screen the entire population now that we know that India is the diabetes capital of the world? But still, there are these, conditions, or there are these criteria where which you use for screening, which is not lab centric but patient centric. So, this screening for diabetes mellitus at a younger age group, say maybe even 35 or so, is recommended in all cases of obesity, family history of diabetes, father, mother, a maternal aunt, maternal uncle, history of pre-diabetes or impaired glucose tolerance. We discussed those values. History of gestational diabetes. I've had one child and I've had gestational diabetes diagnosed. It became normal after the birth of my child, but I still will screen you and monitor you annually. Associated dyslipidemia. So you have high triglycerides, high cholesterol, high LDL, or I am hypertensive. So if any of these conditions applies to you, then it is better that one starts getting screened for diabetes. So at least in your annual checkup, a HbA1c is added or a fasting glucose is added so that you will be able to catch the disease earlier. So annual screening tests should today include glycated hemoglobin and a fasting glucose, if not a postprandial glucose. So these are the recommendations where screening is mandatory at an earlier age. What is gestational diabetes? It's impaired glucose tolerance during pregnancy. Because the requirement of glucose, the requirement of other things is higher during pregnancy. And how do we define it? As a 2-hour post glucose value greater than or equal to 140 milligrams per deciliter after an oral glucose administration of 75 grams, irrespective of whether the patient is in a fasting or a non-fasting state. So this is the definition of gestational diabetes. So the screening for which we use a glucose challenge test, as was discussed to you in an earlier module, where you give 50 grams of glucose and do a 1-hour post glucose, which should be less than 140 milligrams per deciliter. That glucose challenge test for pregnancy or during pregnancy is preferably done during the 24 to 28 weeks of pregnancy, which is the second trimester. But in those cases which I mentioned earlier, where you're obese, you have a family history, you have dyslipidemia, or your previous pregnancy, you've had gestational diabetes, you can even do it in the first trimester, which is 12 to 16 weeks of pregnancy, and repeat it in the last trimester, which is 32 to 34 weeks of pregnancy. Now, screening for diabetes or monitoring the patient post-pregnancy to see whether the glucose levels are normal or increased is mandatory, because many of the women who are gestational diabetics and who may have the other risk factors will turn out to be diabetics post-pregnancy also. Also, many of these patients who develop gestational diabetes will not revert to normal glucose post-pregnancy but may go on to become diabetic. So it's important to screen these patients, to test these patients regularly after you've made a diagnosis of gestational diabetes. Glycated hemoglobin assay is not a very useful test in pregnancy. Now, the other tests are blood glucose fasting postprandial, OGTT, glycated hemoglobin, ketones in the urine and blood, insulin fasting postprandial, C-peptide fasting postprandial. We've discussed all these tests at length. We've learned how useful they are, or whether they are useful, when they are useful, when they're not useful, and how to do these tests. Now you've diagnosed somebody, you've put them on treatment. How do you monitor them? You have to tell them to come back after every 3 months and annually. So every 3 months we do a glycated hemoglobin, we do a glucose fasting and postprandial, and to diagnose early renal involvement, we do a urine albumin creatinine ratio. Some of the drugs that the patient may be on could affect the kidney, could affect the liver, could affect the other parameters, other organs. So we will also do urea creatinine again to make sure that the patient is stable nephrologically. Liver function tests, because the drugs can affect the functioning of the liver, so liver function tests at least annually, and lipid profile to ensure that there is no dyslipidemia, that all your lipid profile is normal, and to make sure that that this dyslipidemia does not become an added risk factor for diabetes. So we use these simple uh, array of tests to monitor diabetes mellitus. Now this is what we do in the lab. We tell the patient to come back every 3 months and we do this, and lipid profile and liver function tests and all you can do annually. Now, apart from this, what we see with all diabetics is self-monitoring of glucose, using a glucometer strip, and looking at your glucose at home, whether daily or whatever the doctor is recommending. So this is very common. These are strip-based methods, and it uses either glucose oxidase or glucose dehydrogenase enzyme catalyzed reactions. Now, this is a test which is done using whole blood. The reagents are combined in a dry form on the surface of the strip. So you use the glucometer, you make a small, using a lancet that is provided in the glucometer, you make a small pinprick or a prick on your finger, and using that drop of blood, you make sure that by capillary action, it enters into the strip. There the chemical reaction occurs, and these meters use either reflectance photometry or electrochemistry, measures the rate of reaction and therefore the concentration of glucose. So you will get a glucose value when you use these strips. Now we also learned earlier that whole blood glucose is 10 to 15% lower than glucose measured in the plasma or the serum. So if I measure the glucose today and go immediately and do a fasting blood sugar or a random blood sugar, the value given by the lab will be higher than the value that I obtain using the strip at home or otherwise. Now, this is a very easy test. It can be done in the comfort of your home. These strips are easily available, probably a little expensive, but all of us can use it and do it at home. You don't have to rush to the laboratory. You don't have to give venous blood. You don't have to wait for the results. Here you know your results immediately. What is the flip side? These meters need to be calibrated regularly. When the guy sells you the glucometer, he doesn't tell you that these need regular calibration. Also, the strips should be subject to quality control and comparison with glucose levels measured by analyzers in the laboratory. At least somewhere you should come to the lab once in a way and check your glucose and see whether the values are correlating. The calibration usually in the glucometer is a chip-based method or it's auto-calibrated. Now, to do quality control, these control solutions are supplied by the device manufacturers, or sometimes the laboratory may make these control solutions and supply it. So you have to get your device calibrated and subject to quality control regularly if you want to believe that the values that you get out of it are reliable. This is very, very important when you're using this self-monitoring devices. The lab values and the glucometer values should not differ by more than 12%. And you should also bear in mind that at very low values and very high values of glucose, the glucometer is not reliable. So less than 60 and greater than 600, you can't totally rely on the glucometer. Now, low hematocrit or low hemoglobin, defective strips, high humidity, not closing the box properly, leaving it open, subjecting it to humidity, high triglyceride levels, very heavy temperature, it should be maintained at that ambient temperature, hypotension, all this will affect the assay. The way you perform the assay, where you poke, should be poked at the side of the fingertip and not at the center of the fingertip. You should not be squeezing your finger and bringing out the fluid. It will be diluted blood. So there are so many variables to getting a proper diagnosis using the glucometer, though the glucometer is a very popular method of monitoring blood glucose. But somewhere one should bear in mind that the calibration, regular controls, comparison with the laboratory, the unreliability at very low and very high levels of glucose, and the various factors that can affect the reading like low hemoglobin, high humidity, not closing it properly, high triglycerides, temperature, hypotension, and so on. So, though it is commonly used, very easy to use, it comes with a certain amount of issues and a certain disadvantages. Now we also know that we have what are called implanted sensors, especially used in those patients where the glucose level is fluctuating. If I measure my glucose level 4 times a day and find that the variability is very high, it's not following a definite pattern. Even if I eat, my sugars are falling, or even if I don't eat, my sugars are very high. Then we used what are called implanted biosensors or continual monitoring of glucose. Just like you have the Holter to continuously monitor your heart, you have these biosensors which will continually monitor your blood glucose levels. So these detection systems are based on enzymes or electrodes or fluorescence. And the common sensor is an electrochemical sensor, and you implant it subcutaneously either here or in your arm, and these devices use glucose oxidase. So it's continuously measuring what is the glucose level in your body. Every 1 to 5 minutes, depending upon the sensor you use, the glucose is measured. This will be collected, stored, and it will be sent to a device, and from that device you'll be able to get a recording of it. You'll be able to get a value which can be either printed out, transmitted to your phone, or kept in the connected to a computer, and you can analyze it. But those devices itself need to be calibrated. And you should also understand that the changes in the glucose levels in the interstitial fluid occurs later than the changes in the blood. These sensors are not planted within the blood vessel. It's planted in the tissue, immediate subcutaneous tissue, which means that it will measure the glucose in the interstitial fluid. And that change in that glucose will happen later than the change that occurs in the blood. But however, for continual monitoring of glucose, these devices are very useful. A well-calibrated device is a very useful device to monitor the fluctuations in glucose levels. Thereby, the diabetologist will be able to adjust and regulate the medication and give adequately when the levels are high and withdraw the medication when the levels are low. So these implanted sensors are now gaining a lot of popularity, especially post-COVID where we are seeing huge fluctuations in blood glucose levels. These are very popular. So as we end this session, what is it that we have understood? What are the key factors that we will take home? Is that India is the diabetes capital of the world. There are plenty of tests which are used to diagnose, monitor diabetes mellitus, and the most important among them are glycated hemoglobin, plasma glucose values, and or OGTT. We have a list of conditions which are risk factors or premorbidities or comorbidities, and such individuals should be screened at an earlier age to check whether they have diabetes. Diabetes is treatable. Diabetes needs to be monitored regularly. And if we understand that, we will understand that all the tests that we do in the laboratory to diagnose diabetes need to be tests that are from standard companies which are approved by the regulators, done in calibrated instruments with proper internal quality control, subject to external quality assurance, reported by skilled individuals and people who have the expertise to report such tests, because it's not just numbers that are getting transferred. You have to understand whether these values correlate and whether they make sense or not at the end of the day. So I hope that over these last 4 modules you have understood diabetes better, understand how we can decode diabetes mellitus in the laboratory, understood the pros and cons of the test, understood the principles of the test, and you are today better informed. Thank you very much and happy learning with